everybody. I'm Jamie. I'm one of the PGY-3s. I'm going to be talking about the EFAST exam today. Thank you to the Ultrasound team, Dr. Galan, DeBella, Dr. Kilpatrick, Hannison, Dr. Lee, Lyoskia, and the Fitz. All right, so what is the FAST exam? EFAST, Extended Focused Assessment with Sonography in Trauma. So this is meant to be a rapid screening tool used to rule in intra-abdominal free fluid, pericardial effusion, or pneumothorax in unstable trauma patients. So I kind of want to break down this statement with the most important words. So this is meant to be a rapid test. This is not a test that should be taking prolonged amount of time, delaying any kind of life-saving care, delaying any kind of necessary imaging or time to the OR. This is a screening tool. This is a rule-in test. You're not using an EFAST exam to rule out severe intra-abdominal injury, meaning that if your EFAST exam is negative, that is not the end of your story there. There is more workup that needs to be done at that time. But it is the data that we'll go through shows that it is a pretty good screening rule-in test. The other thing I emphasize here is unstable. So the initial usage of the EFAST exam was intended to be used in unstable trauma patients as this initial decision-making point for if these patients can go for imaging or need to go straight to the OR for laparotomy. That being said, there are certain uses for this in stable patients, and a lot of the data and information about EFAST exams are studies that included stable patients. So we'll talk more about that. Type of trauma I'm just going to touch on. So the initial development of the EFAST exam was for usage in blunt abdominal trauma. That being said, it is something that we do use in penetrating trauma as well. What I'll say about this is, as far as penetrating trauma goes, the best usage of the EFAST is for rapid identification of a traumatic pericardial effusion or pneumothorax. Just think critically in these scenarios. If you have a patient with a deep penetrating abdominal stab wound that penetrates through the musculature, that patient most likely has intra-abdominal injury. And again, even if you have a negative FAST in that scenario, probably not going to preclude them from getting additional images, probably going to the OR. So just be thinking critically about how you're using it. Just one other thing to consider thinking about this definition. The use of EFAST is going to change based on your setting. So we are a level 1 trauma center. We have rapid access to CT scanners, and we have a trauma team available at all times. If you are in rural settings, wilderness settings, military settings where you do not have access to a CT scanner, this becomes a much more widely used tool. It's going to be expanded to those stable patients, to other injuries that we might not utilize it for, because it's going to maybe be the decision point, not for OR or CT, but this might be what makes you decide if you need to transfer a patient to get further imaging. So just some things to think about. That's a schematic at the top there that kind of goes through the different views, which we'll go through one by one. So some of the data about the EFAST exam. So there's a very wide range when you start looking at what are the sensitivity, specificity for this exam. The sensitivity specifically, looking at even just a handful of studies, it can range anywhere from 42 to 74%. However, the specificity, 91 to 99%. So again, this hones in on this is a rule-in test. If you have a positive FAST exam, the specificity is very good in the setting of trauma, especially in unstable patients, that this patient has an intra-abdominal free fluid injury. And that is a patient that could be taken to the OR. The sensitivities, wider range. Just because your FAST exam is negative does not mean that you can move on and say, okay, great, this patient does not have intra-abdominal injury. Kind of similarly, looking at the likelihood ratios for this, the positive likelihood ratio ranging anywhere from 18 to 82, and the negative likelihood ratio 0.27 to 1, so not really useful. Something else to just think about when we're talking about, again, unstable versus stable patients. Most of the studies use a mix of both. It's rare to find a study that only focused on stable or unstable, but what I found is the ones who did a separate statistical analysis of unstable patients or who only included unstable patients had the highest reported sensitivities and specificities. Just a note for pediatrics, the sensitivity is pretty remarkably lower, 27.8 to 35%. So especially in pediatrics, you cannot be relying on your FAST exam. The specificity is still pretty good, the 91 to 96%. Then how much fluid do we need to have a positive FAST exam? There's a little bit of mixed data on this, but from most reliably what I could find, the sensitivity for like a hemothorax, you maybe only need 20 mils of fluid to have a positive ultrasound finding a hemothorax. For intra-abdominal fluid, basically the studies that were done on true patients found that probably the lower end of what you detect is around 200 mils, but on some like cadaver studies, you theoretically could see anywhere from 30 mils up. But this kind of lends to part of the explanation of why you can have false negative FAST exams for intra-abdominal fluid. So why do we use it? Focusing specifically on the intra-abdominal scans for blunt trauma, study in 2006 showed they basically had physicians decide what they wanted to do with a trauma patient prior to doing a FAST exam and then doing the FAST and then making an ultimate decision afterwards. They found that doing the FAST exam changed management of the patient in 32.8% of cases. DPL, so deep peritoneal lavage, which we don't really see done pretty much ever anymore because of the utilization of the FAST exam, was prevented in 25 patients, and the rates of uses of DPL decreased from 9% to 1%. Another study in 2006 showed that out of 262 randomized patients, the fasted patients had a decreased time to OR, which was 48 minutes versus 76 minutes for those patients that did not receive FAST exams. These patients also had fewer CAT scans, fewer days in the hospital, fewer complications, and decreased hospital stay cost. Lastly, there was a study in 1996 that just basically was looking at what changes are happening in the field of initial trauma management since introduction of the FAST, and it showed that there was a decreased rate in the DPLs and in CT scans, as well as increased diagnostic yield of these tests, just meaning that because they were kind of doing this initial screening examination with the FAST exam, when they were doing DPLs, when they were doing CT scans, they were more likely to actually yield positive findings. Looking specifically at the usage for pericardial effusions and trauma, there were two big studies done that looked at specifically penetrating cardiac trauma. So a study in 2002 showed it was a randomized trial of people getting echoes, not getting echoes. There was 100% survival of the echo group and 57.1% survival in the non-echo group, with a time to diagnosis or OR 15 minutes versus 42 minutes. You can imagine for a rapidly accumulating bloody pericardial effusion, those 30 minutes could be the difference in a life. And then in 1999, another study that showed 100% sensitivity and 97% specificity for traumatic pericardial effusions, and again, showed a very impressive ultrasound to OR time of 12 minutes. They didn't do a comparison. This was just an observational study. Lastly, looking at the extension of the FAST exam to the EFAST, so including the evaluation for pneumothorax. Basically, there's just a bunch of studies that show that the sensitivity of POCUS versus chest X-ray is that POCUS sensitivity for pneumothorax is superior to chest X-ray. One of the considerations of this is probably to do with patient positioning. So these studies are specifically, we're comparing POCUS to supine chest X-rays. When you have a lot of like specific trauma patients, when they're unstable with specific injuries, you can't always sit them up to get that appropriate chest X-ray. You have to think about the air being like gravity dependent. So if you have a patient that's supine, the air is going to be in the anterior air field. So you can imagine when you get that just one view AP chest X-ray, it's very easy to miss some pneumothorax. Versus when you're doing your POCUS, you are specifically looking in the anterior chest while the patient is supine. So you're looking at that most air dependent area. So this is basically the algorithm that we're working with. You have a trauma patient come in. If that patient is unstable, you're still, again, this is not delaying or precluding any part of your primary survey and immediate patient care. So you still need to get your ABCs. You're still doing your secondary survey. Kind of as the end part of your secondary survey, that's where the FAST exam comes in. If your FAST exam is positive in an unstable trauma patient, that patient is going straight to the OR. If your FAST exam is negative, then it is a discussion from there. It does not mean they do not have intra-abdominal injury. If they are able to make it to the CT scanner, you can do that. If they might, depending on how they look, what the injury is, what your suspicion is. Again, if you have a penetrating deep abdominal wound, that patient's probably going to the OR for laparotomy regardless. But in blunt trauma, that's a very important decision point. For your stable patients, again, the FAST exam is helpful, but this isn't the primary usage for it. If a FAST exam is positive in a stable patient, you are still taking that patient to CT. There are injuries that you could miss. and also it gives you a better idea of where the specific injury is. It's very helpful for our surgeons if they're able to get a CAT scan that shows that the patient has a liver laceration causing their injury, rather than taking them blindly to the OR to do a full laparotomy and search every organ for the source of the bleeding. If you have a stable patient, their FAST is negative, again, you have to use your clinical judgment and determine what other imaging is needed. This mention here, serial EFAST exams, observation, serial abdominal exams, those are going to come into play into those some other settings when you do not have immediate access to CTs, immediate access to trauma. These serial exams might be what leads you to make the decision to transfer a patient or not who is stable. So how do we do the FAST exam? So we'll go through each view one by one. So this is a little schematic of the anatomy that you're working with. And I kind of like having this image because I think it can give you an idea of what is the specific anatomy you're looking at, and so what are the adjustments you might need to make if you're not getting the image you want. So for the right upper quadrant approach, you're going to be using a curvilinear probe. You're going to have the probe marker facing the patient's head. This is the anatomy of what you're looking at. The initial view you're trying to get is of that Morrison's pouch, kind of the most identifiable area. And then the other important thing here is that you need to be scanning inferiorly, as you can see in this image, inferiorly to the caudal tip of the liver. The caudal tip of the liver is actually the most sensitive aspect of the FAST exam. So if you are not getting the full liver tip in your view, you have not gotten a complete right upper quadrant view. If you're doing the scan and you're seeing lungs, you can see now here, okay, I need to slide inferiorly. If all I'm seeing is liver, maybe I need to fan posteriorly. So just be thinking about your anatomy and how you can adjust your image. So here's an example of a normal right upper quadrant sono, kind of outlining some of the anatomy here. Looking for that Morrison's pouch, you can see the diaphragmatic and hepatic interface there. And again, wanting to scan some inferiorly, a little anteriorly to get that liver tip. Here are some examples of positive right upper quadrant sonos. So the first image on the left just shows a pretty classic. This is what you expect. This is what you learn in med school. Morrison's pouch, black free fluid in the space there. The image on the bottom right shows that much more subtle finding of blood that just sitting at the caudal liver tip. If you were to just have gotten the FAST view, you can see in this image, there's no free fluid in the Morrison's pouch, it's all just sitting at that gravity-dependent part of the inferior tip of the liver. The top right just shows a couple other things you might see. So you're still getting that Morrison's pouch area. You are seeing free fluid in between the kidney and the liver. You're also getting a view of diaphragm, which assuming the case of trauma is probably a hemothorax. So you're seeing that black fluid above the diaphragm as well as the spine sign. So the hyperechoic thing along the bottom of that image is the spine. You should not be able to see spine above the level of the diaphragm. The lungs are not a good, the sound does not travel well through that. And so usually it obscures the imaging of the spine. If you're seeing the spine above the diaphragm, that's a sign that there's fluid involved. Some pitfalls, why would we have false negatives, false positives on the right upper quadrant? For false positives, there's liver vasculature, the IVC, hepatic veins, the portal veins, bile ducts that can all potentially give you you see fluid there. So you need to be making sure if you're seeing that, you're tracing it through and not seeing that it's related to the vasculature. Also, you can have perinephric fat, which is the image in that top right. So you do see a hypoechoic, pretty black line right in that Morrison's pouch area. The way that you can differentiate this from free fluid is the lining around that is very hyperechoic, which is more indicative of perinephric fat. Moving on to the left upper quadrant. So again, we have this schematic. You're looking in the left upper quadrant. You have the spleen, the kidney, the diaphragm there. The approach to this view, curvilinear again, probe marker to the patient head. The typical teaching is your knuckles are going to be on the bed, that this view tends to be way more posterior than you expect it to be. Keep in mind that when you're sliding your probe posteriorly, you also need to be cognizant of the angle of your probe. If your knuckles are to the bed, but your probe marker is pointed upwards anteriorly, you're not going to be getting the appropriate view. You need to make sure you have it posteriorly and are pointing either straight or posteriorly. For this view, classically, again, I think in med school, a lot of times we're taught looking at that interface between the spleen and the kidney. And similar to right upper quadrant, this is not the most dependent area of this view. The most important area to get here is both the inferior edge of the spleen, as well as the interface between the diaphragm and the spleen. So this is an image of what you can expect to see. The dynamic image on the left, you're getting diaphragm, you're seeing that interface there without any fluid, as well as that kidney spleen interface. You're not getting really the full view of the inferior tip of the spleen, so that's something that you might improve on your scan. And then just a schematic of the anatomy there as well. So some positive images from the left upper quadrant. So on the left, we have, again, kind of a little bit more classic. You're seeing fluid in that interface between the spleen and the kidney. If you look closely towards the end of the clip, you can also see fluid in that space between the spleen and the diaphragm. So again, it's very important to get that. This view tends to be very difficult, just like the anatomy is difficult. The spleen isn't always, it's not as prominent as the liver. The ribs often get in the way. So you may have to do some finagling working in between the rib spaces to get all these images. On the bottom right is a much more subtle positive finding, which you're seeing just some fluid at that posterior edge of the spleen, not really seeing much right in that like interface between the spleen and the kidney. And then at the top are just some still images of some potential places you can see fluid. So you see some subphrenic free fluid in that typical splenorenal space, but then also the paracolic gutter, which is basically the inferior edge of the spleen, is another place where you can like see isolated free fluid. Pitfalls for the left upper quadrant, other than it just being the most difficult view, it takes a little bit more patience and making sure, again, that you're pointing really posteriorly. Think about what you're seeing and what you're not seeing. Again, if you're seeing lung, you probably have to slide inferiorly. If you're not seeing kidney at all, you probably need to go more posteriorly. There's false positives that can happen here, similar to the right upper quadrant. So perinephric fat can be an issue, both for right upper quadrant and this one, ascites. Not going to be able to differentiate between that and blood. The stomach is in this area as well, can sometimes have some like mixed hypoechoic, hyperechoic that can make you confused. And other failures of the left upper quadrant is really, again, just missing those views, missing that interface between the diaphragm, most specifically. Suprapubic, so this is a view that you're going to get, you need to get two views for this view. So you're going to be using the curvilinear probe, you're going to get your transverse view, probe marker to the patient's right. And you're going to be scanning all the way. You need to see the bladder disappear, reappear fully, and disappear again. That means that you got the full view. The schematic here is showing the sagittal view, so probe marker to patient head. You're looking in that area posterior to the bladder. And then in patients who have a uterus, you're looking in that pouch of Douglas, which is going to be posterior to the uterus. Keeping in mind that, free fluid, if you're seeing it, in any of these areas, but these are kind of the most gravity-dependent areas. So these are some images of normal suprapubic scans. That being said, these are incomplete scans. This is just because the gets cut off, but this would not be a sufficient exam because you're not seeing it all the way end to end. So just something to keep in mind. So some examples of positive suprapubic scans. In the dynamic image on the bottom left, you can see actually uterus floating in free fluid there. And so you're seeing bladder above, but then you're seeing this much more ill-defined structure. You have to know your anatomy. If you don't know your anatomy and you don't know that the uterus is going to be in that area, you might be very confused by what you're seeing here. On the bottom right is a dynamic image of a positive sagittal view. So again, we're seeing that fluid posterior to the bladder. And then the top two views, I like the image with the labels, just because it also includes the visualization of the prostate, which can also have a relatively hypoechoic view in the center of it, and you have to not confuse that with free fluid. But you're seeing the free fluid accumulate in a very irregular pattern around the prostate. And then the top right is a classic free fluid behind the uterus and Douglas. Some pitfalls for the suprapubic, false positive. So again, rectum, prostate, vagina, all of these things can have relative hypoechoic views that might make you second guess if you're seeing free fluid there. So you're looking for something that's irregular and something that is not consistent with the anatomy that you know. Failure to fan completely through in both dimensions. And then also failure to adjust the gain. If a patient has a very large bladder, that's going to be a very significant acoustic window. You see in that top right image. If you don't adjust your gain, you might just be drowning out visualization of free fluid posterior to the bladder. Subxiphoid. So just, I'm kind of going through these images in the typical way that you would if a patient came in unstable with blunt abdominal trauma. Think critically. If your patient has a stab wound to the left chest, you're probably going to do your subxiphoid view first. It's going to be, subxiphoid and pneumothorax evaluation first. So to do this view, you're going to probably have the curvilinear probe in your hand. You can just use that. Typically, when we're doing echoes, we use the cardiac probe. Either will work. You want to have the overhand approach, and you're going to have this probe pretty flattened against the patient's abdomen in order to get this view. If you're not seeing what you need to see, one of the approaches you can do is to slide the probe slightly towards the right and then angle towards the heart using the liver as an acoustic window, because sound waves travel really well through that. Things that are going to make this view difficult: pain, especially if they have a severe intra-abdominal injury, abdominal distension, bowel gas are all things that can make this a really difficult view to get. If you are trying and are unable, or patient is unable to tolerate this exam, you can use a parasternal long view to look for pericardial effusion instead. This is just the most, because you're getting the inferior part of the heart, this is the most sensitive for pericardial effusion, but you have to work with what you have. So here are some images. What you're going to be looking at is the interface between the right ventricle and the liver. That's kind of the space that you're looking for the effusion. And here's just a normal dynamic image there. Some examples of some positive findings. So you're seeing free fluid, more or less. The other thing you have to take into consideration, if you do have an unstable patient and you do see something like this, is trying to evaluate for tamponade physiology. In the bottom right, you have an image. I just think it's interesting because you have the obvious, the dark black free fluid, but there's also a lot of clotted blood in there, which is not going to appear as hypoechoic. So, assuming if all of that was clotted, that could be a really tricky exam. If it was smaller, more subtle, you have to think about the fact that blood can be clotting and will not appear so hypoechoic. Some pitfalls, one being the fat pad. So there is an epicardial fat pad that can lie across the ventricles. The best way to make sure that what you're seeing is actually effusion is that you need to see it tracing around the entire heart. So getting additional views are going to be the most helpful way. If you see it tracking along the posterior edge of the heart, you can be pretty reassured that that is an effusion, but it looks pretty similar in these images. All right, and then the lungs. So for this view, again, if you have the time, you're doing the exam separately. A lot of times we'll use the linear probe to be looking for this, but you have the curvilinear in your hand. It works just as well. You're just going to have to decrease your depth so that you're getting a better view of the actual pleural line. We're not looking for B lines here. We're looking just at that pleural line. Again, we're talking about the air being position dependent. So your patient needs to be supine when you're doing this exam and you're looking in the anterior chest. If your patient's sitting up and you're scanning near the nipple line, you're going to miss a possible pneumothorax. So this is the image you're looking for. You see the anatomy, rib shadows. You're looking at that bright white pleural line. You're going to see A lines, which is just that artifact that happens. That's normal. And what you're looking for is what you're seeing on the bottom right. It's typically taught as ants on a log. You're basically just seeing movement across that pleural line. When you are in a very busy trauma and the trauma surgeon is across the end of the bed and already doesn't trust the probe in our hands, and you're trying to figure out if there is actually a pneumothorax, it can be really hard for everyone in the room to trust that they're seeing lung sliding. So what we often do is use M mode. So M mode in the ultrasound, you're taking this one physical point, and you're looking at it over time. So what you want to see, what is normal, which is shown here, is the seashore sign. So you have those horizontal lines at the top, and then it becomes this grainy, fuzzy area as you go below the pleura, and that's because of the movement that's happening in the lung. So versus, this is the barcode sign, which is what we see in the case of there being a pneumothorax. There's an example of the dynamic image here. You're seeing you're not seeing that glittering movement across the pleura. You can almost see it like being tight, trying to move, and there's just no movement there. Pitfalls for missing pneumothoraxes. Primarily, there was a study that was done that showed the most common reason that ER doctors miss pneumothoraxes and then later those images are reviewed and they can see it, is missing a lung point. So lung point meaning that you actually found the exact edge of that pneumothorax. So if you see in this top right dynamic image, you can see pretty good lung sliding there. But if you see right where that red arrow is and to the left of it, there's no movement there. This is actually the most specific, sensitive, pathognomonic finding you can have for a pneumothorax, but it can often be missed if you're not being thorough in what you're seeing. On that bottom right image, you can actually see where they scanned in two different lung fields. And in one rib space, they have lung sliding. And then as soon as they go over to the lung space next to it, there's nothing. So again, that would be very sensitive specific. And then just an example of the M mode where you actually see the transition where it's more barcode on the left side, and then you can see that graininess coming in when you hit the lung. Just some general pitfalls. I mentioned it briefly. Ascites, you cannot differentiate ascites from free fluid. It is free fluid, so you can't differentiate it from traumatic blood. So just keep that in mind. Coagulated blood can happen in, I showed it in the echo. It can happen in any view. So here's a view of a suprapubic with clotted blood posterior to the bladder. It's pretty, it's not super hypoechoic. So you are seeing some level of irregularity. Again, if you're thinking about your anatomy, you can tell something's not quite right there, but you have to think about it. And then just keeping in mind, just because, again, your FAST is negative, there are a lot of injuries that will be not detected on a FAST exam, including retroperitoneal bleeds, femoral artery bleeds, muscle belly artery bleeds. All of these things are going to have negative FAST exams and still are going to require emergent treatment. So summary, the FAST exam has high specificity for intra-abdominal free fluid, leads to decreased use of DPL, CT scans, and faster time to definitive treatment. It is a rule-in test, not a rule-out test. FAST has high sensitivity and specificity for penetrating cardiac injury and leads to increased survival and faster time to definitive treatment for traumatic pericardial effusions. And EFAST has higher sensitivity for pneumothorax when compared to supine chest X-ray, assuming you're using appropriate positioning in your POCUS. Unstable patients, positive FAST, OR. Stable patients, positive FAST, further testing. Unstable patients, negative FAST, further testing. That's kind of the emphasis here. And just make sure that you just know your anatomy, know what you're looking for, be patient, take your time scanning thoroughly through the entire views. I know it can get really hectic when the trauma senior is breathing down your neck, but you really need to take the time and make sure that you're getting all of the views. Yeah.